Okay, the next defect is Tetralogy of Fallot, TOF. So first we'll start off with the mechanism. Now it starts off with abnormal neural crest cell migration. Because of this, we have an improper development of the conotruncal septum. Conotruncal septum is the outflow tract, the tract through which the blood flows out of the heart. So the aorta and the pulmonary artery. So those are the two places we are referring to. So what that does is it causes an anterior-superior displacement of the infundibular septum, and that causes a malalignment of the aorticopulmonary septum. This is the same thing that spirals as well, right? So it causes malalignment. So what that does is we now have an unequal division of the truncus arteriosus. Truncus arteriosus is through which the aorta comes out and the pulmonary artery comes out. So what happens, or what ends up happening, is the aorta has a larger diameter versus a smaller pulmonary artery, right? Now, because the pulmonary artery is on the smaller side, if we kind of continue our talk, well, actually, let me take a step back. So before saying what I was about to say, when we take a look at this slide, again, it seems very overwhelming, a lot of different information. So we'll break it down. On this slide, we'll first talk about what are the four major defects in the Tetralogy of Fallot, the cause of those defects, the mechanism of what those defects are causing, and the clinical features. How does that appear clinically, right? So from the previous slide, we mentioned that the aorta is larger and the pulmonary artery is smaller. So what happens is the patient develops pulmonary stenosis. In other words, the valve itself is not really affected, but it's more so the pulmonary artery. In other words, there is a lot of right ventricular outflow tract obstruction. The blood is not able to leave the right ventricle properly. The cause here is that anterior deviation of the infundibular septum, right? So imagine now we have a narrowed right ventricular outflow. So if you take a look on this diagram, we have a narrowed right ventricular outflow, pulmonic stenosis, let's say. It increases the pressure in the right ventricle. So pressure in the right ventricle increases. And because these patients also have a VSD, that increased pressure pushes the blood through that VSD onto the left side of the heart. So from the right, it goes to the left side. So that becomes a right to left shunt through the VSD. Now, the outflow tract obstruction, this is what determines the severity of the condition. Very, very important concept and a question in both COMLEX as well as the USMLE exams. What determines the severity of the TOF? It's the degree of the pulmonic stenosis, the degree of the right ventricular outflow tract obstruction. Clinical features here is because the blood is trying to leave the heart, ejection murmur, a harsh systolic ejection murmur, and this is heard at the left upper sternal border. Now, if the patient, if we have said that the blood from the right ventricle goes into the left ventricle, the blood is not really going through the lungs, it's not becoming oxygenated. Which is why, if this happens, the patient has the cyanosis and the TET spells. And again, we'll talk more about the TET spells and what are all the different things that go on there. But the TET spells takes place, worsens with exertion and relieved by squatting. We'll again talk about the mechanism in a bit. The next one is right ventricular hypertrophy. Now, if the patient is not able to push blood out into the pulmonary artery, a lot of pressure will build up in the right ventricle, which also means that the right ventricular will be hypertrophied, work-induced hypertrophy, a concentric hypertrophy. So due to increased afterload from the pulmonary stenosis or the outflow tract obstruction. So right ventricular pressure increases, concentric hypertrophy. And on a chest x-ray, we have a picture about this for this one. Later on, we'll take a look at it. This is called the boot-shaped heart, or it gives the heart a boot shape. The third point is, the third defect is the overriding aorta. So overriding is the larger aorta that we had seen. The larger degree of the aorta, the diameter of the aorta is a lot larger compared to the pulmonary artery. So that is the overriding aorta because of the malalignment of the aorticopulmonary septum. So aorta receives, in this case, blood from both the right as well as the left ventricles because of that malalignment. So now we have a mixture of the oxygenated blood and the deoxygenated blood, and that mixture, the mixed blood, is going out into the systemic circulation. And that is why the patient can also present with cyanosis. Again, it also depends on the degree of the shunting. The fourth one here is a VSD. So VSD forms because of failure of the conotruncal septation. Conotruncal septation we have talked about a couple of times now. So that leads to a right to left shunting due to the high right ventricular pressures. So yep, we have definitely seen that. More pressure on the right side, the shunt goes towards the left side. And a VSD will be a hollow systolic murmur. We have seen that term before as well. Pansystolic, hollow systolic, heard at the left lower sternal border. Right. So those are the four things you definitely want to know. What causes those things? What is if someone has those things, what are the clinical features and how does it all work? Because the questions nowadays are getting into a lot more of those details. Okay, so next we'll kind of add on to that concept. We'll first take a look at the left side of the picture. Here we have the acyanotic oxygen saturation. So imagine from the superior vena cava and the inferior vena cava, the unoxygenated blood is coming into the right atrium. So let's say 75% saturated. From here, it goes into through the tricuspid valve. It goes into the into the right ventricle, and then from the right ventricle, it goes through the pulmonic valve. Again, at this point, let's say it's a pretty mild condition, mild to moderate obstruction, so the blood can still go through. From here, the blood goes into the pulmonary artery. From here, it goes into the lungs, and from the lungs, it becomes oxygenated and it comes back into the left atrium. So that is a higher oxygen saturation, right? Through the mitral valve, it goes into the left ventricle. But now the thing is, we have a VSD in TOF, right? So that oxygenated blood from there, it goes into back into the right side, and that's why the saturation is a lot higher on this side now, right? Because normally, if 75% of the unsaturated blood is coming, that's the same amount or the same saturation should be seen in this case. But now we have a step up. There's a step up of oxygenation because of this VSD, right? So currently in a mild to moderate obstruction, patient, let's say, doesn't have any symptoms. This is a left to right shunt through the VSD. Now, what exactly, we mentioned the term TET spell. So what happens in a TET spell? What is a TET spell? So anytime the kid is crying, they're feeding, exertion, they're running around, they're agitated, what that does is it increases the pulmonary vascular resistance. So it causes a bit of a constriction. It increases the resistance and it decreases the systemic vascular resistance, meaning the aorta, right? So it decreases the systemic vascular resistance. So what happens is it causes a lot more obstruction. The right ventricular obstruction becomes a lot more severe. So what happens now is the same amount of saturation that is in the right atrium comes into the right ventricle. But because the blood can't go forward because of that severe obstruction, the pressure builds up in the right ventricle, and now it pushes past that VSD, and all that blood now goes towards the left ventricle. And you see how in the left ventricle, normally left ventricle has a higher oxygen saturation because it's receiving it from the lungs. Here we have a step down. We have 80% compared to, let's say, a normal of 98%. So we have a step down of the oxygen saturation because of the blood coming in from the right side. So now this is a right to left shunt through that VSD. So to kind of summarize that, during the TET spell, because again, this is that up and down arrow question that the questions love to ask, the pressure in the right ventricle is increased because during a TET spell, the obstruction is a lot more severe. The blood can't go into the pulmonary artery, so the pressure in the right ventricle increases. The pulmonary artery pressure is decreased And again, this is the overall pulmonary pressure. And then the left atrial pressure is also decreased because there is no blood flow in that area. So pulmonary artery pressure is decreased and the left atrial pressure is decreased because the blood is not really able to reach in those areas. Now, in terms of initial diagnostic testing, we definitely want to do an EKG. EKG will show a right ventricular hypertrophy because of all the reasons we have mentioned. Chest X-ray, this is what will show a boot-shaped heart. A boot-shaped heart, so the right, because of what's going on in terms of the TET spells and what's happening to the left ventricle has a lot of volume coming in, so it kind of enlarges and looks like a boot shape. The best diagnostic test with this one is an echocardiography, and management is we give them, because the patient has cyanosis, we would give them oxygen. And what the oxygen is doing is two things. The oxygen is stimulating the pulmonary vasodilation, because see, hypoxia causes vasoconstriction in the lung blood vessels. So if we give them oxygen, so we are reversing the hypoxia, it would cause a vasodilation, meaning the blood vessels in the lungs can receive a lot more blood supply. So that's one very important function of oxygen, mechanism of oxygen. And secondly, oxygen also causes systemic vasoconstriction. Now, why would a systemic vasoconstriction be required, and why would a pulmonary vasodilation be required? So if we go back up here, we'll take a look at the picture on the right. Imagine two things are happening. Let's start with the aorta. Aorta is a systemic circulation. In the slide after this, we had mentioned there is vasoconstriction in the systemic circulation. So imagine the aorta and the systemic circulation, there's a vasoconstriction. The pressure increases, which means it makes it more difficult for the left ventricle to pump blood out into the systemic circulation, right? So that's one thing that's happening. So what that does is it increases the pressure in the left ventricle. That pressure now translates or it moves the blood towards the right ventricle. The second mechanism is by giving them oxygen, we are also vasodilating the arteries in the lungs. So if the arteries are in the lungs are vasodilated, they are able to receive a lot more blood supply. So a lot of pressure in the left ventricle because of the systemic vasoconstriction pushes the fluid or the blood back into the right ventricle, and then it goes past that obstruction into the lungs. It becomes oxygenated, and now it comes back to the left side and eventually goes back into the circulation, and that relieves the TET spells, or it relieves the cyanosis that the patient might be experiencing. Now, another way to achieve the same thing is a knee to chest position. And again, patients will say that the kid runs around, he feels tired, and he squats. So knee to chest position. So what that is doing, it's also increasing the systemic vascular resistance. So what happens is the pressure in the aorta increases, the pressure in the left ventricle increases, which means the shunt is reversed. More blood and more pressure in the right ventricle, and it's able to push past that obstruction. And now everything is back to normal in terms of that cyanosis. And if it's very, very severe, it's not really corrected by any of those other things, surgical repair around 4 to 6 months. One other important association with the TOF is the DiGeorge syndrome. So a lot of DiGeorge syndrome patients, they also are found to have the Tetralogy of Fallot.